Welcome back to the deep dive. If you need a comprehensive, focused pathway through the most critical concepts in respiratory health, the kind that shows up on exams and really determines patient outcomes, then you are in exactly the right place.
You are.
Today, we are undertaking a massive deep dive, synthesizing the entire spectrum of acute and chronic respiratory disorders. And we're pulling every essential nugget directly from Chapter 19 of Brunner and Sutter's Medical Surgical Nursing.
That's right. And our mission today is explicitly tailored for you, the learner. We're building a structured, organized approach to this material.
Okay.
We're going to move chronologically from, the foundational definitions all the way to complex management of mechanical ventilation and chest trauma.
So not just listing sacks.
No, absolutely not. We're going to focus on the pathophysiology, the priority nursing interventions, and the crucial assessment findings that allow you to distinguish one emergency from another.
We are essentially creating a clinical shortcut to confidence. And to start strong, I think we have to establish a solid vocabulary base.
Absolutely.
We've got 4 core concepts that, they just underpin every discussion about respiratory compromise.
Let's lock these in. The first one is really understanding the most severe end of lung failure. We often hear 2 terms, acute lung injury, or ALI, and acute respiratory distress syndrome, ARDS.
Right.
We now view ALI as, well, it's the umbrella term. It's essentially equivalent to mild ARDS.
Okay, so it's a spectrum.
It's a spectrum. ARDS itself is a severe systemic inflammatory response that impacts the lungs non-specifically. It's defined by bilateral infiltrates, alveolar hemorrhage, severely reduced lung compliance, we're talking stiff lungs, and most critically, refractory hypoxemia.
Refractory hypoxemia. That's the key phrase, isn't it?
It is.
Because it tells you exactly why ARDS treatment is so different. But let's step back and define the difference between low oxygen states. Hypoxemia versus hypoxia. They sound almost identical.
And this is a fundamental distinction. Think of your body as a city's plumbing system. Hypoxemia is a decreased oxygen tension, specifically in the arterial blood, so a low PaO2. That's like having low pressure in the main water pipe feeding the city. Hypoxia is the broader problem. It's the decreased oxygen supply reaching the actual cells and tissues of the body.
So your faucet is running dry.
Your faucet is running dry. While hypoxemia usually causes hypoxia, you can have tissue hypoxia even with a normal PORO if, say, you have severe anemia or cyanide poisoning that prevents the cells from even using the oxygen.
Moving into the machinery to support then.
Yeah.
We constantly use PEEP and FiORO in critical care settings. What are those functions?
So PEEP stands for positive end-expiratory pressure. When you breathe out, the pressure usually returns to 0. PEEP artificially maintains a positive pressure in the airways at the end of exhalation.
And its job is?
Its vital job is to increase the functional residual capacity, which translates to physically pushing open and keeping open collapsed alveoli. Without PEEP, those units would just collapse every single time the patient exhales.
And FiORO?
FiORO, the fraction of inspired oxygen, is simply the concentration of oxygen being delivered. Room air is 21%, or 0.21.
And finally, the condition that really sets the stage for so many later complications. Atelectasis.
Atelectasis is the closure or, the airless condition of the alveoli. And this isn't just an academic term. Clinically, it is the single most common abnormality found on a chest X-ray in the hospitalized patient population.
Okay, let's jump right into the collapse itself, atelectasis. You mentioned it's the most common abnormality, but why does it happen? How do we differentiate the types of collapse?
Yeah. Well, we classify the collapse based on mechanism, either non-obstructive or obstructive. Non-obstructive atelectasis is when the lungs simply aren't ventilated well, which you often see in just generally deconditioned adults.
Right.
However, the most common type is obstructive atelectasis. This happens when a blockage, like a mucus plug, a tumor, or a foreign body, prevents air from getting into a lung unit.
And the air that's already in there.
That's the key. The air that was already trapped there is gradually reabsorbed into the bloodstream, and the whole unit just collapses because no new it can replace it.
It seems almost counterintuitive that something as simple as lying flat or shallow breathing can cause a collapse. But the sources really emphasize postoperative risk.
They do.
Walk us through that perfect storm mechanism that's described in the textbook's clinical illustrations.
Postoperative patients are a super high-risk group, and it's because of multiple simultaneous mechanisms. First, anesthesia and analgesic agents, they suppress the central
So
drive.
you don't feel like breathing.
You don't. It leads to this monotonous, low tidal volume breathing pattern. Second, if they have an incision, they involuntarily splint their chest wall due to pain.
Right. It hurts to take a deep breath.
It hurts. So they take these shallow, ineffective breaths. Third, they have retained secretions and an impaired cough reflex. Figure 19:1 in the book beautifully illustrates how this cycle, hypoventilation, reduced lung volume, and secretion retention, just guarantees alveolar collapse.
And then there's compressive atelectasis, where the problem isn't the air pathway, but external pressure.
Exactly. Imagine a balloon being squeezed. This happens when there's excessive pressure applied onto the lung tissue. The classic culprits are a pleural effusion, which is fluid,
Okay.
a pneumothorax, which is air, or a hemothorax, which is blood in that pleural space. Even something like an elevated diaphragm, maybe from abdominal distension or increased intra-abdominal pressure, can exert enough force to restrict lung expansion.
When you're assessing a patient, what are the red flags for atelectasis? How do you spot the subtle onset versus, the severe acute event?
The onset is often really gradual. You might just notice increasing dyspnea, maybe a mild cough, and increased sputum.
Right.
But if the collapse involves a large segment, what we call lobar atelectasis, the patient will show marked respiratory distress. We're talking tachycardia, rapid breathing, or tachypnea, and sometimes pleuric chest pain.
And cyanosis.
Central cyanosis is an urgent but late sign indicating profound hypoxemia. Clinically, these patients are anxious, and they often prefer the orthomic position sitting upright because lying flat just makes it so much harder to breathe.
The quality and safety alert in this section really reinforces that tachypnea, dyspnea, and hypoxemia are the hallmarks of severity. So what should you expect on physical assessment?
You'll typically find increased work of breathing. On auscultation over the affected area, you're going to hear decreased breath sounds or possibly crackles, and critically, the pulse oximetry reading often dips below 90%.
Which just tells you gas exchange is significantly impaired.
Exactly. And the long-term danger, particularly in chronic atelectasis, is that this collapsed, airless area is the perfect breeding ground for a distal infection, escalating the problem into a full-blown pneumonia.
So the primary nursing goal is prevention and reversal. What are those first-line, non-invasive things a nurse can do right now to get those alveoli open?
The initial interventions are simple, but they have to be performed consistently. We prioritize frequent turning and repositioning, early and aggressive mobilization, actually getting the patient out of bed, and voluntary deep breathing maneuvers performed at least every 2 hours.
And this is where the incentive spirometer comes in.
This is where incentive spirometry, or IS, reigns supreme.
Let's not just say use the IS. We know it's often done incorrectly, which just defeats the whole purpose.
Yeah.
Walk us through the step-by-step instruction a nurse must give a patient for effective IS use.
Okay, this is critical. The goal of IS is to maximize lung inflation slowly and deeply. First, you have to position the patient in a semi-Fowler or upright position. Then, the patient has to be coached to use diaphragmatic breathing, pushing the belly out as they breathe in.
Not using their shoulders.
Not their shoulders. They place the mouthpiece firmly in their mouth, inspire slowly and deeply through the mouth, aiming to sustain the maximum volume. They need to hold that breath for about 3 seconds at the peak to keep the indicator steady.
And how often?
They must repeat this 10 times in succession every single waking hour. And for post-op patients, reinforcing that they splint their incision when they cough is absolutely non-negotiable.
That focus on the slow, sustained inspiration, not fast sucking, is so key. Now, the modern insight isn't just about IS, it's about standardizing care into a bundle. The source material highlights the ICOUGH program. What's the thinking behind this standardized approach?
The insight here is moving from, ad hoc, inconsistent care to a standardized, evidence-based bundle. Compliance across all 6 elements of ICOUGH dramatically cuts down on readmissions and complications.
So what does it stand for?
The mnemonic covers I for incentive spirometry, C for coughing and deep breathing, O for oral care, which includes brushing teeth and using mouthwash twice a day to reduce the oral bacterial load.
Okay.
U is for understanding, so patient and staff education. G is getting out of bed at least 3 times daily. And H is head of bed elevation.
And if these non-invasive measures fail, what are the advanced interventions for persistent atelectasis?
So if the underlying cause is thick, retained secretions, we move to directed cough, CPT, aerosol nebulizer treatments, or possibly even a bronchoscopy to physically get in there and remove the mucus plug.
And if the alveoli just stay closed?
Then we introduce positive pressure, PEEP delivered via a simple mask and a one-way valve, or continuous positive airway breathing, CPAP. If the condition is massive and severe enough to cause acute respiratory failure, then we have to escalate to endotracheal intubation and mechanical ventilation.
And for the compressive causes?
For the compressive causes, like a large pleural effusion, the treatment is procedural. A thoracentesis, or a chest tube insertion to remove the fluid or air that's causing the problem.
Atelectasis so often invites infection. Let's shift our focus to inflammation, starting with acute tracheobronchitis. Why does inflammation of the tracheal and bronchial mucous membranes often lead to a secondary infection?
Well, it's because the initial inflammation, which is often due to a viral infection, compromises the integrity of the mucosa. This decreases the host's local resistance, leaving the airway vulnerable to colonization by secondary pathogens like S. pneumonia, H. influenza, or M. pneumonia.
And that leads to the productive cough.
Exactly. The inflammation generates a productive cough that produces mucopurulent sputum.
How does the clinical picture evolve?
It usually starts as a dry, irritating cough, and then it progresses to one producing purulent or maybe even blood-streaked sputum because of the irritation. The patient reports sternal soreness, fever, chills, and just generalized malaise. On assessment, you might hear noisy inspiration or stridor or expiration, which is wheeze.
And management is mostly symptomatic.
Largely symptomatic, yeah. If a bacterial infection is confirmed, we use targeted antibiotics.
And the nursing focus on secretion management here is different than in simple atelectasis, right?
Yes. Here we push fluids. Increased fluid intake really helps thin those viscous secretions, making them easier to clear. We also rely on cool vapor or steam inhalation for soothing the irritated laryngeal and tracheal mucosa.
Is there anything to avoid?
Yes. A critical point emphasized in the chapter is to avoid antihistamines. Their drying effect will just thicken secretions further, worsening the obstruction and the cough. Nursing management also involves educating the patient on the absolute necessity of adequate rest to prevent a relapse or exacerbation.
Pneumonia is a major global health concern. The classification is essential because it guides our immediate empiric choice of antibiotics, especially with drug resistance.
Absolutely.
Let's break down the 4 types outlined in chart 19-4.
Okay, starting with location. Community-acquired pneumonia, CAP, occurs either in the community or within the first 48 hours of admission. The major distinction comes next with healthcare-associated pneumonia, HCAP.
And what's that?
This applies to non-hospitalized patients who have had extensive recent contact with the healthcare system. For example, a recent hospitalization, residence in a nursing home, or recent infusion or wound care.
Why is HDAP so important to single out?
This is the primary clinical insight. An HCP classification means we immediately bypass the standard CAP antibiotics because that patient is highly likely to be carrying hospital-grade or multi-drug-resistant organisms, MDROs.
So you have to go bigger with the drugs from the start.
Much bigger. The empiric therapy must be much broader and more aggressive.
Okay, what about the other 2?
The remaining 2 are truly nosocomial. Hospital-acquired pneumonia, HAP, develops 48 hours or more after admission, provided it wasn't incubating on arrival. HAP is associated with high mortality, up to 33%.
Wow.
And ventilator-associated pneumonia, VAP, is a subtype of HAP, developing 48 hours or more after the initiation of an endotracheal tube, and it represents one of the greatest critical care complications.
Who is at risk? Table 19-2 and chart 19-5 lists so many risk factors. What are the top 3 that every nurse needs to screen for immediately?
Okay, top 3. First, smoking and underlying chronic lung disease like COPD, heart failure, or alcoholism. Smoking just disrupts the ciliary action and macrophage function, destroying the airway's first line of defense.
Right.
Second, immobility and positioning. Supine positioning and shallow breathing prevent alveolar recruitment. And third, advanced age and depressed reflexes, because the cough and glottic reflexes are often impaired, which dramatically increases the risk of aspiration.
And there are pathogen-specific risks, too.
There are. Specifically, age over 65, alcoholism, or recent beta-lactam therapy. Those predispose the patient to drug-resistant S. pneumonia.
Regarding the underlying process, how does the inflammatory response manifest differently in the lungs, leading to those anatomical classifications?
So, pneumonia starts when altered host resistance allows pathogens or aspirated material to invade. This triggers inflammation, leading to edema and exudation in the alveolar area. Lobar pneumonia affects a substantial contiguous portion of one or more lobes, leading to this uniform consolidation on imaging.
And bronchial pneumonia.
Bronchial pneumonia, however, is patchy. It originates in the bronchioles and spreads outwards. This is actually the more common form, and it often leads to scattered consolidation on an X-ray.
The source material stresses that you can't diagnose the causative organism based on symptoms alone, but certain classic presentations can point you in the right direction.
For sure. For classic streptococcal pneumonia, the presentation is often sudden and dramatic. High fever, rigors and chills, marked pleuritic chest pain, and profound tachypnea, often 25 to 45 breaths per minute, coupled with visible accessory muscle use.
You contrast this with atypical pneumonia.
You do. Atypical or viral pneumonia is gradual. Low-grade fever, headache, myalgia, malaise. And while purulent or blood-tinged sputum might occur, relying on sputum color like the classic rusty sputum is really unreliable for a definitive etiology.
A critical sidebar here is gerontologic considerations. What does the nurse look for when that classic presentation is masked or absent in older adults?
This is a vital quality and safety consideration. The classic fever and cough might be totally absent, gone.
So what do you look for instead?
Instead, you have to look for non-respiratory signs. Generalized deterioration, weakness, anorexia, sudden confusion or altered mental status, unexplained tachycardia, and new tachypnea.
And a chest X-ray is key.
A chest X-ray is non-negotiable here. It's often required to differentiate pneumonia from an acute exacerbation of chronic heart failure, as both can present with very similar nonspecific systemic symptoms.
Once it's suspected, how do you get a proper sputum culture, minimizing contamination from all the oral flora?
The patient should first rinse their mouth with water. Then they need to take several deep breaths, followed by a deep, forceful cough, expelling the material directly into a sterile container.
And if they can't cough effectively?
If the patient is too wet or compromised, then more invasive means are necessary, like naso or orotracheal suctioning, or, for the most compromised patients, a fiber optic bronchoscopy to get a protected specimen.
Management focuses on reaching clinical stability. Let's look at the criteria for switching a patient from IV to oral antibiotics. This is so important for discharge planning.
It is. The clinical stability definition is precise. The patient must demonstrate stability across 6 key parameters. Temperature less than or equal to 37.8 Celsius, heart rate less than or equal to 100, respiratory rate less than or equal to 24, systolic BP greater than or equal to 90, O2 saturation greater than or equal to 90%, and they have to be maintaining oral intake with a normal mental status.
If they meet all of those, they can switch.
If they meet all those, they can typically transition to oral therapy.
And underlying all of these pharmacologic decisions is the principle of antibiotic stewardship. Why is the CDC pushing this so hard?
Because of the relentless rise of MDROs, MRSA, VRE, drug-resistant S pneumonia, stewardship involves coordinated strategies to optimize antibiotic use.
It's not about restricting antibiotics, though.
Not at all. It's about using the right one for the right duration to reduce resistance patterns, prevent unnecessary secondary infections like C. difficile, and decrease overall costs. The CDC mandates that all acute care hospitals have these programs in place.
And for viral pneumonia, treatment is supportive. What does that involve?
Hydration is crucial, as the fever and tachypnea lead to significant insensible fluid loss. We use antipyretics and antitussives symptomatically, and oxygen therapy is titrated via pulse oximetry.
And if they deteriorate?
If the patient deteriorates, high FiORs is required, often necessitating ET intubation and mechanical ventilation.
The SARS-CoV-2 pandemic fundamentally shifted some respiratory management strategies. Walk us through how that virus operates and the clinical course.
So SARS-CoV-2, a community-acquired coronavirus, enters the body by binding to ACE2 receptors, which are highly abundant in the type 2 alveolar cells and the vascular endothelial cells of the lung.
And most people had a mild illness.
The majority of patients, thankfully, experience mild illness, fever, cough, anosmia, that kind of thing.
For those mild outpatient cases, the CDC criteria for ending self-quarantine are very specific.
They are. They must be fever-free for at least 72 hours without the use of any antipyretic medication. They must show improvement in respiratory symptoms, and a minimum of 10 days must have passed since the symptom onset.
It's a multi-factor approach.
It is. It ensures they are past the most infectious phase.
If the disease progresses to moderate severity requiring hospitalization, there are specific protocols, including the avoidance of certain aerosolizing procedures.
That's right. For moderate disease, which is defined by pneumonia evidence, but SPRO is still above 93% on room air, we see inflammatory lab markers. We avoid routine antibiotics unless a bacterial superinfection is suspected.
And what about VTE?
Given the extremely high risk of venous thromboembolism, anticoagulant prophylaxis, typically LMWH, is standard of care.
Okay, a critical safety point that emerged during the pandemic concerned aerosol generation.
It did. To protect staff, inhaled medications should be administered using a pressurized metered dose inhaler, a PMDI, rather than a small volume nebulizer or SVN whenever possible.
Why is that?
Because SVNs just generate significantly more airborne droplets. Isolation is mandatory, requiring an airborne infection isolation room and strict PPE use.
And for severe disease, especially with ARDS, the initial management strategy was, well, it was controversial and evolved really rapidly.
It did. Severe disease is SPROs less than 93% on room air and marked tachypnea, often leading to mechanical ventilation. Early in the pandemic, the high mortality associated with mechanical ventilation led clinicians to try strategies to delay intubation.
Right.
And one highly successful strategy was utilizing periodic prone positioning combined with high-flow oxygen therapy for non-intubated patients.
And that helps out.
The maneuver helps shift fluid, redistribute perfusion, and recruit dependent lung areas, and it often improves oxygenation dramatically.
Pharmacologically, what is the core of treatment for severe COVID-19 ARDS?
Supportive care remains paramount. The antiviral remdesivir is generally recommended for improving recovery times. We also saw investigational therapies like IL-6 antagonists such as tocilizumab used to mitigate the dangerous systemic inflammation known as the cytokine storm.
So the nursing process here is centered on diligent monitoring and airway clearance. What are the key elements of assessment?
Beyond routine vital signs, you have to monitor the quality and quantity of secretions, the frequency and severity of the cough, and continuously assess for physical exam changes, new crackles, or signs of consolidation like increased tactile fremitus or egophony.
And especially in older adults.
Especially, you have to be hypervigilant for nonspecific signs in older adults, monitoring for confusion, signs of heart failure, and dehydration.
How does the nurse actively intervene to address the primary diagnosis of impaired airway clearance?
We use mechanical and voluntary methods. This includes teaching the directed cough sequence, slow, deep breath, momentary glottic closure, muscle contraction, and then an explosive, effective expiration.
And CPT.
We implement chest physiotherapy and postural drainage, positioning the patient to drain specific lung segments, followed by percussion and vibration. And of course, we constantly administer and titrate oxygen, monitoring its effectiveness via pulse oximetry or ABG.
Hydration is crucial, but you have to walk a tightrope, especially with cardiac patients.
That's absolutely correct. We aim for at least 2 liters of fluid a day because the fever and tachypnea lead to significant insensible fluid losses, which thicken secretions. But in patients with known heart failure or renal dysfunction, you have to monitor intake and output like a hawk, listening for new crackles and watching for signs of peripheral edema, which could indicate fluid overload.
When you're monitoring for complications, how quickly should you expect to see a clinical response after starting antibiotics?
Improvement should be evident within 24 to 48 hours. Persistent fever or worsening symptoms is a major warning sign.
Suggests failure.
It suggests failure. Either the patient has a medication allergy, the pathogen is drug resistant, or there's a complication like the development of a pleural effusion or an underlying obstructive disorder like lung cancer causing continued atelectasis.
And you're also watching for things like septic shock and delirium.
Constantly. We assess for deterioration into septic shock and actively screen for delirium using tools like the confusion assessment method, or CAM, because new confusion in a respiratory patient is a very poor prognostic sign.
Let's move to aspiration, the inhalation of foreign material, which is a catastrophic event. What factors determine the ultimate damage that's caused?
It is entirely dependent on the volume and the character of the aspirate. If the material is colonized oral or pharyngeal flora, you get bacterial aspiration pneumonia, often caused by S. aureus or anaerobes.
And if it's not bacterial?
The non-bacterial aspiration of acidic gastric contents is arguably more destructive. It causes an immediate severe chemical pneumonitis, just destroying alveoli and capillaries. Or if solid food particles are inhaled, the danger is acute mechanical blockage.
The list of risk factors in Chart 19-8 is extensive. What do all these conditions, seizure activity, stroke, flat positioning, have in common?
They all compromise the patient's ability to protect their airway, either by decreasing their level of consciousness or impairing the swallowing mechanism, what we call dysphagia. We see high risk with decreased LOC due to sedation, anesthesia, or trauma, as well as with pre-existing disorders like GEA, strictures, or stroke.
The nurse's primary role, then, is prevention. Let's focus on the crucial prevention practices, especially related to tube feedings.
Prevention is the battle. We have to maintain head-of-bed elevation 30 to 45 degrees and use sedatives sparingly. For enteral tube feedings, the tip location must be confirmed, and you need to assess placement and gastric residuals every 4 hours.
What's the target for residuals?
Residuals typically need to be kept below 150 milliliters, and we avoid rapid bolus feedings in high-risk patients. For intubated patients, we maintain appropriate ET cuff pressure and, crucially, clear secretions above the cuff before deflation to prevent contents from dumping into the lungs.
You also mentioned silent aspiration. What makes that so dangerous?
Silent aspiration occurs unobserved, often in patients with non-functioning or clamped nasogastric tubes. Gastric contents accumulate, and hours later, a massive inhalation can occur because the patient has no warning symptoms.
And post-extubation.
Post-extubation, due to potential edema and nerve damage, patients must undergo a swallowing screen by a speech therapist. When eating, they should sit semi-recumbent, take small bites, use the chin tuck maneuver, and never ever use straws.
Why no straws?
Because straws increase the risk of air and content misdirection.
Okay, let's move to pulmonary tuberculosis, an infection caused by M. tuberculosis. Transmission is airborne via droplet nuclei, a true person-to-person spread. How does the body contain this infection initially?
When a susceptible person inhales the bacilli, they multiply in the alveoli. The immune system responds aggressively, forming these specialized lesions called granulomas, which are masses of live and dead bacilli surrounded by macrophages.
And those become a gone tubercle.
They fibrose into a gontoprobricle. At this point, the bacteria usually enter a dormant state, and the disease is arrested. Only about 10% of infected individuals will ever develop active symptomatic disease, often due to reactivation years later when their immunity is compromised.
Chart 1910 details the risk factors. What are the major patient populations we have to screen meticulously?
We have to prioritize screening the immunocompromised, so HIV-positive patients, those on chemotherapy or high-dose corticosteroids, and those living in conditions with inadequate health care, like people experiencing homelessness or poverty.
And other high-risk groups.
Immigration from high-prevalence countries and institutionalization prisons, long-term care are also major risks. And of course, healthcare workers, particularly those performing aerosol-generating procedures like suctioning.
What are the classic, albeit insidious, signs of active TB?
The onset is gradual. Low-grade fever, fatigue, unexplained weight loss, and those characteristic night sweats. The cough can range from non-productive to mucopurulent, and hemoptysis, coughing up blood, may occur.
And again, with older adults.
Remember the gerontologic considerations. Older adults often present with atypical signs like new confusion or altered mental status.
Diagnosis relies on the Mantoux TST. We need precise clarity on the induration thresholds.
Okay, the Mantoux TST involves depositing PPD intradermally, and we measure the hardness or induration in millimeters 48 to 72 hours later. A non-significant reaction is 0 to 4 millimeters.
That's significant.
A reading of 5 millimeters or greater is considered significant for the highest risk groups: HIV positive, recent close contacts, or those with X-ray evidence of old TB. A reading of 10 millimeters or greater is usually significant for people with normal or mildly impaired immunity.
You confirm with the sputum culture.
We do. An AFB smear suggests disease, but the culture confirms it. Crucially, due to global resistance, the initial isolate must immediately be tested for drug resistance. We are battling MDR TB resistant to isoniazid and rifampin, and even XDR TB, which is even more resistant. The pharmacologic management is long and onerous. What are the 4 first-line agents, and what is the overarching challenge of that 6 to 12-month regimen? The 4 first-line drugs are isoniazid, which is INH, rifampin, pyrazinamide, or PZA, and ethambutol. INH is often given with vitamin B6 to prevent peripheral neuritis.
And the regimen itself.
The regimen starts with an initial intensive phase for 8 weeks, using typically 4 drugs, followed by a continuation phase lasting 4 to 7 months, often with just isoniazid and rifampin.
The primary challenge has to be adherence.
Oh, it is.
How does the nursing team enforce this to prevent transmission and failure?
Adherence is the absolute failure point of TB treatment. This is why we have to stress that TB is communicable, And non-adherence risks transmission and developing resistance. The solution for non-adherent patients is directly observed therapy, or DOT.
Where someone literally watches them take the pills.
A healthcare provider watches the patient ingest the medication daily. Patients become non-infectious after 2 to 3 weeks of continuous therapy, but the full regimen has to be completed.
And you're monitoring side effects constantly.
Constantly. You have to watch closely for signs of hepatotoxicity, an elevated LFT, nausea, dark urine, jaundice, which is commonly associated with isoniazid and rifampin. We also monitor for neurotoxicity and educate the patient on required frequent vision checks because of ethambutol, which can cause optic neuritis.
Finally, quickly describe miliary TB.
Miliary TB is the dreaded systemic dissemination of the infection through the bloodstream to non-pulmonary sites, liver, spleen, meninges. It requires immediate aggressive treatment and intensive monitoring for systemic signs like high temperature spikes and changes in renal or cognitive function.
Let's move to a lung abscess. It's a contained pocket of pus, usually from aspiration of anaerobic bacteria. Who is at highest risk, and where does the abscess typically form?
The risk factors are similar to aspiration: impaired consciousness due to CNS disorders, substance use disorder, or anesthesia. And because the location is gravity dependent in a bed-confined patient, it typically forms in the posterior segment of an upper lobe or the superior segment of a lower lobe.
And management focuses on long-term IV antibiotics and drainage.
Exactly. Treatment requires 5E antimicrobial therapy for 3 weeks or longer to sterilize that necrotic core, often using clindamycin or ampicillin sulbactam. Adequate drainage is crucial, which we achieve through postural drainage and CPT.
And nutrition is a big factor.
A huge factor. We have to address the patient's nutritional status, providing a high-protein, high-calorie diet, because chronic infection leads to significant catabolism. Surgery, like a lobectomy, is rare, reserved only for massive hemoptysis or non-response.
Okay, let's discuss sarcoidosis. This is an inflammatory multisystem granulomatous disease of unknown cause, and it often affects the lungs. How is it diagnosed, and what's the primary treatment?
Diagnosis relies on imaging chest X-rays or CT scans that show hilar adenopathy and miliary or nodular lesions. Confirmation is achieved via biopsy showing non-case-eating granulomas.
And treatment.
Many patients remit spontaneously, but if the disease is symptomatic or involves critical organs like the eyes, heart, or has extensive lung disease, the primary treatment is corticosteroids, like prednisone, often tapered over 12 months. Immunomodulators like methotrexate might be added for refractory cases.
Now for the pleural disorders. These conditions involve the pleural lining, starting with pleurisy or pleuritis, the inflammation of the pleural layers. What is the distinguishing symptom, and how do you manage it?
The distinguishing symptom is sharp chest pain that is severely aggravated by deep breathing, coughing, or any movement. Nursing management is simple comfort, instructing the patient to splint the chest with their hands or a pillow during a cough,
Right.
and encouraging the patient to turn and lie down on the affected side, which acts as a sort of internal splinting.
Next, pleural effusion fluid accumulation. Can you differentiate between transudate and exudate fluid types for us?
This is a key diagnostic distinction. Transudate is clear, plasma filtrate. It suggests intact capillaries but increased hydrostatic pressure, classically caused by heart failure or cirrhosis.
And exudate.
Exudate is fluid extravasation due to diseased pleural membranes, meaning the membranes themselves are leaking or inflamed. This is classically caused by infection, cancer, or TB.
When you're assessing a patient with a large effusion, what are the characteristic physical findings?
You'll hear decreased or absent breath sounds over the fluid area. Tactile fremitus will be decreased or absent, and percussion over the fluid will produce a dull or flat sound, indicating density.
And a very large effusion is an emergency.
It's dangerous because it causes acute respiratory distress and may result in tracheal deviation away from the affected side. Management requires treating the underlying cause and using thoracentesis or chest tube insertion for symptom relief and fluid analysis.
Finally, empyema, the most severe pleural disorder, a collection of thick, purulent fluid pus. Why is this so difficult to drain?
Empyema is difficult because the pus is often loculated.
Loculated.
It means the body has walled off the infection site with fibrin, creating multiple separate pockets. A standard chest tube often only drains one of those pockets.
So the treatment has to be more aggressive.
Much more aggressive. It requires 4 to 6 weeks of large-dose IV antibiotics and aggressive drainage methods. For loculated fluid, we may need to instill thrombolytic agents like TPA through the chest tube to break down those fibrin walls. For chronic, thick exudate, open chest drainage via rubrisection may be necessary to fully evacuate the cavity.
Let's turn to acute respiratory failure, or ARF. It's a life-threatening, sudden deterioration of gas exchange. Give us the non-negotiable definition criteria.
The definition is based on 3 concurrent lab values. Severe hypoxemia, which is a PaO less than 60, and E-hypercapnia, a PECO over 50, and accompanying acidosis, so a pH less than 7.35, all 3.
The causes are widespread, from the central nervous system to the pulmonary system. What is the primary cause in the postoperative patient?
In the postoperative setting, ARF is often due to VQ mismatching caused by pain, anesthesia, or sedative effects that suppress respiratory drive. Other causes include CNS trauma or overdose, neuromuscular disorders like myasthenia gravis or Guillain-Barré, or pulmonary diseases like ARDS or pneumonia.
What are the early clinical manifestations of ARF that the nurse absolutely must catch?
The early signs are subtle. Restlessness, fatigue, headache, air hunger, tachycardia, and increased blood pressure. As gas exchange worsens, the signs become urgent. Confusion, lethargy, central cyanosis, diaphoresis, and visible use of accessory muscles.
And management is stabilization.
Exactly. Treating the underlying cause and aggressively supporting ventilation, which almost always means mechanical ventilation.
When intubation is required, the nurse's immediate post-intubation duties are crucial for safety. What is the step-by-step confirmation process?
This is a high-stakes moment. First, you check chest symmetry and auscultate breath sounds bilaterally to ensure the tube isn't misplaced in the esophagus or slipped down into a single bronchus.
Right.
Second, you immediately obtain capnography or end-tidal chireo to confirm the tube is in the airway. Third, placement must be verified definitively with a chest X-ray. Only then should the tube be secured, the cuff pressure checked, and an oral airway or bite block inserted if the tube is oral to prevent obstruction.
For long-term ventilation, a tracheostomy may be required. What are the core nursing care priorities for a patient with an artificial airway, focusing on preventing complications?
Airway patency via appropriate suctioning is paramount. The patient should be positioned in semi-Fowler. We must administer warm humidity to prevent secretions from drying and forming plugs.
And cuff management.
Cuff management is critical. The pressure must be maintained at the lowest effective pressure, typically 20 to 25 millimeters of mercury, to ensure adequate tidal volume delivery while preventing tracheal ischemia. This pressure has to be checked with a handheld gauge at least every 8 hours.
And infection control.
Of course. We prioritize infection control using sterile technique for all suctioning and care.
Why is inline suctioning often preferred, and how did the pandemic modify its use?
Inline or closed, suctioning is preferred because it allows rapid suctioning without disconnecting the patient from the ventilator circuit. This minimizes hypoxemia and maintains the necessary PEEP.
But it's not perfectly closed.
Exactly. The insight from COVID-19 showed that even with inline suctioning, the process generates enough aerosol to necessitate the continuous use of strict PPE for airborne pathogens.
When the patient is finally extubated, what are the immediate post-extubation recovery steps?
The patient receives heated humidity and oxygen by face mask, maintaining a high Fowler position to maximize lung expansion. We monitor very closely for stridor, that harsh, high-pitched sound indicating laryngeal edema or any color change.
And PO status.
The patient is kept MPO or given only ice chips for the first few hours, and we immediately reinforce deep breathing and coughing exercises to prevent a subsequent atelectasis.
Okay, mechanical ventilation. This requires strict physiological criteria. Name the key thresholds.
Indications include severe compromise, a PO less than 55, a PECO over 50 with a pH less than 7.32, or a vital capacity less than 10 millivels per kilogram. Clinically, apnea, severe distress, or circulatory shock also necessitate initiation.
Let's simplify the two major types of positive pressure ventilators. Volume cycled versus pressure cycled. What is the fundamental difference in safety?
The difference is what the ventilator prioritizes. Volume-cycled ventilators prioritize volume. They deliver a preset tidal volume, making the delivered volume consistent and reliable. The pressure required may vary.
And pressure cycle?
Pressure-cycled ventilators prioritize pressure. They deliver flow until a preset pressure is reached. The major limitation here is that if lung compliance worsens, if the lungs get stiffer, the volume delivered may decrease dramatically, potentially leading to hypoventilation.
So volume cycling is safer for unstable lungs.
It's safer for patients with fluctuating compliance, like in ARDS.
Non-invasive ventilation, NIPPV, is a huge advance. What is the difference between CPAP and BiPAP?
Both use a mask and avoid intubation. CPAP applies continuous positive airway pressure throughout the entire respiratory cycle. It's primarily used to stent airways open in conditions like sleep apnea. The patient has to be breathing spontaneously.
And BiPAP gives more support.
It does. BiPAP allows for independent control of inspiratory pressure, or IPAP, and expiratory pressure, EPAP. This provides tailored support and reduces the work of breathing, and it's often used for nighttime assistance in COPD.
Now for the modes of ventilation. Instead of listing all 6, let's focus on the 3 core modes and how they interact with the patient's own effort.
Okay, the first core mode is CMV, continuous mandatory ventilation, or assist control. Think of this as the machine doing all the heavy lifting.
Okay.
It delivers a preset volume or pressure at a preset rate. Crucially, if the patient attempts to take a breath, the machine senses it and assists by delivering the full mandatory breath. The patient can't take shallow breaths, which provides safety but can lead to overventilation.
Right. And the second core mode.
The second is SIMV, synchronized intermittent mandatory ventilation. This mode is crucial for weaning. The machine delivers a preset number of mandatory breaths synchronized to the patient's effort, but in between those breaths, the patient can take spontaneous breaths where they only generate their own tidal volume.
So you wean by turning down the machine breaths.
Exactly. You gradually decrease the preset machine breaths, forcing the patient to increase their own effort.
And the third.
The third is PSV, pressure support ventilation. This is often layered onto MV or used alone when the patient is spontaneous. It provides a preset level of positive pressure only when the patient triggers a breath, acting like a tailwind to reduce the effort needed to overcome the resistance of the tubing in the airway.
And you wean that down too.
You gradually reduce that pressure as the patient improves.
The nursing process for a ventilated patient is intense. Beyond checking the patient first, what are the constant monitoring priorities?
You have to systematically check the patient lung sounds, color, effort, comfort, and then the machine. We check ET tube position, continuously monitor ventilator settings, and address alarms immediately. Alarm management is absolutely paramount.
We discussed alarm fatigue. How does the critical care team manage this systemic risk?
Alarm fatigue occurs when constant, irrelevant alarms desensitize staff, leading to delays in responding to true emergencies. To counter this, Chart 1913 recommends using protocols for setting appropriate alarm limits based on the patient's condition, managing the physical layout of the unit to reduce noise overload,
And education.
and educating staff that alarms should only be silenced during immediate intervention. They should never, ever be turned off.
Let's focus on the VAP prevention bundle. Airway clearance and infection control are just inseparable in this setting.
They are. The VAP bundle is a cornerstone of critical care nursing. It includes head-of-bed elevation 30 degrees or higher to prevent aspiration. Meticulous oral care is vital because the mouth is the primary source of VAP contamination. The CDC recommends toothbrushing and suctioning of subglottic secretions.
And securing the tube.
We secure the tubing meticulously to prevent accidental extubation, which is a life-threatening complication.
And what about mobility for these critically ill, sometimes sedated patients?
Early mobilization, often assisted by respiratory and physical therapy, is non-negotiable. Getting stable patients out of bed to a chair prevents the rapid decrease in muscle strength, including respiratory muscle strength, that prolongs hospital stays and increases mortality.
And if they can't be mobilized?
If they can't, active or passive range of motion exercises must be performed every 6 to 8 hours.
Finally, communication. The patient is trapped and voiceless. How do you facilitate communication?
First, you assess their existing ability. Can they nod? Can they mouth words? Can they write? Then you provide tools. A pad and pencil, a communication board, or, if applicable, a speaking tracheostomy valve. Simple things like ensuring eyeglasses and hearing aids are available are critical for their sensory perception and ability to receive information.
Positive pressure ventilation is life-saving, but it has severe consequences.
Yeah.
Detail the 2 major categories of complications: cardiac and pulmonary.
Okay, cardiac alterations are predictable. The positive pressure reduces venous return to the heart by compressing the great vessels. This decreases preload, leading to reduced cardiac output and hypertension. You have to aggressively monitor fluid balance, INO, and weight to prevent severe volume depletion.
And pulmonary complications.
Pulmonary complications include barotrauma or volutrauma. This occurs when excessive pressure or volume delivery damages the delicate alveolar membranes, potentially leading to a pneumothorax, a critical emergency signaled by a sudden drop in oxygen saturation or acute distress.
The ABCDEF bundle is presented as a strategy to prevent not just infection, but the long-term cognitive and psychological damage known as post-intensive care syndrome, or PICS. What is the holistic goal of this bundle?
The overall goal is to humanize critical care and prevent PICS, that combination of mental, physical, and emotional issues that plague survivors. The bundle integrates awakening and breathing coordination, which means daily sedation interruptions and spontaneous breathing trials. Choice of sedative and analgesia, favoring non-benzodiazepines, delirium monitoring using the CAM-ICU every 2 to 4 hours, early mobility when safe, and family engagement and empowerment.
The ABC part is clinical, but the D, E, and F are clearly aimed at minimizing psychological trauma.
Precisely. We need to prevent delirium, which is exacerbated by sedatives and immobility. Early mobility, when criteria are met, like an IFIO under 60% and a PEEP under 9, shortens the duration of ventilation. And F, family engagement, is just essential for grounding the patient and providing psychological resilience.
When the patient meets the criteria for weaning, as laid out in Chart 1919, how do you know if the trial is failing?
So weaning criteria are physiological. The cause of failure must be reversed, and the patient has to be hemodynamically stable and spontaneously breathing. During the trial, you have to monitor for failure signs,
Such as
a heart rate increase greater than 20 beats per minute, a systolic blood pressure falling or rising more than 20 millimeters of mercury, a PAHARO falling below 80, or in SPIO dropping below 90, increased use of accessory muscles, or any change in consciousness.
and if that happened.
If any of those occur, the weaning trial must be immediately terminated and the patient returned to full support.
Let's talk about ARDS, the most severe manifestation of respiratory failure. You mentioned its hallmark is refractory hypoxemia. What exactly is the pathophysiology of the lung that makes it refractory to oxygen?
ARDS involves a massive inflammatory response that injures the alveolar capillary membrane. Fluid, proteins, and blood leak into the interstitial and alveolar spaces. This inactivates surfactant and causes the alveoli to collapse,
Which creates a mismatch.
It creates severe VQ mismatching and shunting. Think of it this way. Blood is pumped through 5 lanes of traffic, the alveoli, that are completely flooded and closed. That blood is never picking up oxygen.
Nice.
So no matter if we deliver 100% FiO the blood is just shunting around the ventilated areas. That is why it's refractory. Increasing oxygen concentration doesn't fix the flooded lanes.
Sepsis is the most common cause, but what are other major risks listed in Chart 1920?
Aspiration, massive trauma, shock, localized infections like severe pneumonia, including COVID-19, and e-volley, the e-cigarette or vaping injury.
Severity is defined by the PAO to FiO ratio. What are the cutoffs?
This is critical for monitoring and research. A ratio between 200 and 300 is mild ARDS. Between 100 and 200 is moderate ARDS, and anything below 100 is severe ARDS.
Management involves aggressive supportive care and protective ventilation strategies. Why is low tidal volume ventilation so important?
Because the lungs are stiff, high pressures can cause volume trauma or barotrauma. The key strategy is the lung protective strategy, using low tidal volumes, typically 4 to 8 ml per kilogram of ideal body weight. This prevents overstretching the remaining healthy lung tissue.
And a high PEEP.
We also use high PEEP to keep alveoli open, but we have to continuously monitor for barotrauma.
Pharmacologically, what is used to manage synchronization?
The treatment is primarily supportive. We use potent sedatives, often non-benzodiazepines like propofol, and sometimes neuromuscular blocking agents, or paralytics like pancuronium.
And why would you paralyze a patient?
Paralysis is used to achieve complete patient-ventilator synchronization and decrease oxygen consumption. If you are paralyzing a patient, constant sedation and pain management is mandatory, and it's monitored via peripheral nerve stimulators, the Train of 4 test.
We previously noted that COVID-19 ARDs often presented differently. What were the key distinctions in presentation and treatment?
COVID-19 ARDs often had a longer onset, 8 to 12 days from symptom start, and some patients surprisingly maintained better lung compliance than classic ARDs. This distinction led to increased use of strategies like prone positioning for non-intubated patients combined with high-flow oxygen, which just shows how quickly clinical practice has to adapt to new pathogens.
Let's shift to the pulmonary vasculature. Pulmonary hypertension, or PH, is defined by dangerously elevated pressure in the pulmonary artery. What is the pressure threshold and the ultimate consequence?
pH is defined as a mean pulmonary arterial pressure greater than 25 millimeters of mercury at rest. The ultimate consequence of this increased resistance is secondary right heart failure, known as cor pulmonale. The WHO classifies PH into 5 groups based on the underlying cause, ranging from idiopathic PAH to PH due to left heart disease.
Can you describe the pathophysiology of this failure?
Sure, chronic vascular injury triggers smooth muscle hypertrophy and thickening of the pulmonary arterial walls. This severely narrows the vascular bed, forcing the right ventricle to pump blood against massive resistance. Over time, the right ventricle hypertrophies and eventually fails, leading to systemic congestion and decreased cardiac output.
Management is exceptionally complex and often involves continuous infusions. What are the major drug classes used?
Treatment involves managing the underlying cause and general support, like diuretics and oxygen. Pharmacologically, complex delivery systems are common. We use prostanoids like IV epoprostenol, which has an extremely short half-life and requires continuous infusion.
What else?
Endothelin receptor antagonists like bosentan, which requires rigorous monitoring for hepatotoxicity, and phosphodiesterase 5 inhibitors like sildenafil. For refractory cases, lung transplantation is the only surgical option.
Yeah, for occupational lung diseases, these are entirely preventable but not curable. What is the general cause and what is the nursing role in prevention?
They're caused by chronic inhalation of substances like mineral dust silica, asbestos metal dust, or toxic fumes. Because the resulting fibrosis and damage are often irreversible, they are not curable.
So the nursing role is all about prevention.
Purely advocacy and prevention, promoting the use of protective devices and conducting thorough occupational history assessments, job title, exposure levels, time frame to screen high-risk individuals, and track progression.
You give an example.
A key example is silicosis, caused by silica dust, which leads to nodular lesions and massive fibrosis, resulting in restrictive lung disease, PH, and cor pulmonale. Another is coal workers' pneumoconiosis, or black lung, where coal dust deposits cause maculas and localized emphysema, again leading toward respiratory failure.
Let's finish with chest tumors and trauma. Lung cancer is the leading cancer killer in the U.S. What percentage is attributable to the #1 risk factor, and how does SCLC differ from NSCLC?
Over 85% of cases are attributable to inhaled carcinogens, primarily cigarette smoke, which we quantify by pack year history. Small cell lung cancer, SCLC, is highly correlated with smoking, is very aggressive, and responds well initially but relapses quickly.
And non-small cell.
Non-small cell lung cancer, NSCLC, is less aggressive and is usually treated surgically if it's localized.
The assessment challenge is that symptoms are often late. What is the most frequent symptom that should raise suspicion?
The most frequent symptom is a change in a chronic cough. It might become persistent, dry, or productive. Other late signs are dyspnea, hemoptysis, and chest or shoulder pain, which may indicate metastasis, commonly to the lymph nodes, brain, liver, or bone.
So screening is key.
Screening for high-risk smokers age 55 to 80 with a 30-pack-year history with low-dose CT is crucial for early detection.
Surgical management via thoracotomy requires strict postoperative nursing care, particularly around positioning. If I have 2 patients, one post-pneumonectomy and one post-lobectomy, I need a quick rule. Why is the pneumonectomy patient always turned to the operative side?
That's a classic priority question. The goal after a pneumonectomy, the removal of the entire lung, is to allow the fluid in that empty space to consolidate and harden. If you turn the patient onto the non-operative side, you risk the contents shifting and causing a potentially fatal mediastinal shift.
Which compresses the heart and the other lung.
Exactly. It compresses the remaining lung and heart. Therefore, they are turned every hour to the operative side. Conversely, a patient after a lobectomy, removal of one lobe, can be turned to either side to facilitate drainage and lung expansion.
Besides positioning, what are the immediate complications a nurse monitors for, and what's the home care instruction regarding mobility?
We monitor for respiratory distress, cardiac arrhythmias, which are common due to irritation of the vagus nerve, hemorrhage, and pneumothorax. Pain control is vital because poor pain control inhibits deep breathing, leading to atelectasis.
And at home?
For home care, the patient must perform arm and shoulder exercises 5 times daily to restore movement and prevent stiffness, and they must avoid heavy lifting over 20 pounds for several months.
Okay, chest trauma. This demands immediate priorities. Airway, ventilation, and stabilization. Let's contrast 2 critical injuries. Flail chest and tension pneumothorax.
A flail chest involves 3 or more adjacent ribs fractured at 2 or more sites, creating a free-floating segment. The clinical hallmark is paradoxical movement. The segment pulls in on inspiration and pushes out on expiration.
And the management is supportive.
Primarily supportive. pain control, secretion clearance, and, if severe, ventilatory support to internally stabilize the segment.
And attention pneumo.
Attention pneumothorax is an immediate, life-threatening emergency. Air enters the pleural space through a one-way valve mechanism, but it can't escape. The pressure builds rapidly, collapsing the lung and pushing the heart and trachea the mediastinal shift toward the unaffected side.
Which compromises circulation.
It compromises circulation and respiration, leading to potential cardiac arrest. The immediate intervention is needle decompression or chest tube insertion.
What is the management strategy for the most common injury, which is simple rib fractures?
Fractures of ribs 4 through 10 are most common. Fractures of the upper 3 ribs carry high mortality because of associated vessel laceration risk. Management is supportive. Aggressive pain relief, often via intercostal nerve blocks or PCA, and avoiding oversedation to ensure the patient can still deep breathe and cough.
And chest binders.
Chest binders are used for support, not for restriction.
The solution to pneumothorax or large effusions is the chest drainage system. Explain the function of the water seal and the crucial safety concept behind it.
So the drainage system functions to remove air and fluid, re-expand the lung, and critically prevent air and fluid from re-entering the chest. The water seal chamber contains 2 centimeters of water and acts as a one-way valve. The insight here is the pathophysiology. The water maintains the necessary negative pressure in the pleural space.
And the safety alert.
The critical safety alert is this. If the chest tube disconnects from the drainage system, you must immediately immerse the chest tube end in a bottle of sterile water, because this reestablishes the water seal, which prevents atmospheric air-positive pressure from rushing back into the patient's chest and causing a potential fatal tension pneumothorax.
We also have the dry suction water seal system and the Heimlich valve.
Right. Dry suction systems use a mechanical regulator for vacuum control, which makes them more user-friendly. The Heimlich valve is a small, one-way valve used for minimal drainage, often for small, uncomplicated pneumothoraces, and it allows the patient to ambulate more easily.
We have systematically covered the entire spectrum of this crucial chapter, detailing everything from the collapsed alveoli of atelectasis to the complex management of ARDS and the immediate life-saving priorities of chest trauma.
We have, and we've seen that the role of the nurse is not merely reactive, it is profoundly proactive.
How so?
Well, whether it is meticulously teaching the ICOUGH regimen, understanding why HEIP demands specialized empiric therapy, monitoring for the subtle atypical signs of pneumonia in older adults, or ensuring adherence to long-term TB therapy, the difference between success and failure lies in rigorous attention to these clinical details and protocols.
You've given us a powerful, structured breakdown. We saw how clinical practice evolves, especially, in light of the COVID-19 pandemic.
Which brings us to our final provocative thought for you, the learner. We discussed how the pandemic emphasized minimizing aerosolization by favoring pressurized metered dose inhalers, or PMDIs, over small volume nebulizers, SVNs, for infectious patients.
Right.
How might the lessons learned about minimizing droplet dispersal permanently change standard hospital practice for administering inhaled medications to all respiratory patients, regardless of their infection status, as a continuous measure of quality and safety?
Something to mull over as you prepare for your next clinical rotation. Thank you for joining us for this in-depth exploration of respiratory disorders.
We'll see you next time for another deep dive into medical surgical nursing excellence.